Good day, friends, and a warm welcome to the India TB Summit 2022, ahead of World TB Day, where we remind ourselves yet again that there is so much work to be done to get a grip on this diabolical scourge of mankind. My name is Camilla Rodrigues, and I come from the Hinduja Hospital in Mumbai, where I work as a consultant microbiologist. And together with Dr. Puneet Diwan, we are chairing the panel today on equitable and accessible TB diagnostics or TB diagnosis in India with the impact of COVID. Friends, we all know for years that the biggest impediment to TB control has been the long and winding road to diagnosis. The poor accuracy of smear microscopy and the weeks to months long time for culture have really been the Achilles heel in the efforts to eradicate TB. NATs, or nucleic acid amplification tests as they've been called, have really ushered in a new era. And they are either cartridge-based, which is the expert, or chip-based, which is TrueNAT. Accurate and rapid diagnosis, less than 90 minutes, with resistance on board, really has been a game changer for diagnosis of TB, no question about it. At the same time, but we cannot lose sight that timely initiation of anti-TB drugs and follow-up of positive patients is equally vital. And as we in India started to get a handle on this, came COVID. This is really likely to leave a profound and lasting impact on TB diagnosis and control. The reasons are that in the initial lockdown, there was a precipitous fall of 70 to 80% in TB notification rates. It also changed health-seeking behavior, disrupted health services with delayed diagnosis, and interrupted treatment for our patients. The large number of cases that currently remain undiagnosed and untreated will really fuel TB transmission, especially in household contacts where they've been sort of encaged for some time. And this is estimated to be at least 40,000 cases annually, with an increase of almost 1.5 lakh till 2025. So the aftershocks will really be felt long after the COVID epidemic wanes. COVID has additionally made it more challenging to locate TB patients. Poor compliance with TB treatment is a significant reason behind the increase in MDR TB and XDR TB in India. And the numbers are expected to be even higher during and post-COVID. So it's a wake-up call for overburdened health systems across the world, and prevention, diagnosis, tracing and management strategies of TB patients will really need to be restructured and reevaluated to meet the needs of our patients. So now, the remit of our talk is basically, of our panel, is accessible and affordable diagnostics. And before I introduce the speakers, let me thank New Diagnostic Working Group of the Stop TB Partnership for sponsoring this event. My co-chair, Dr. Puneet Diwan, is going to speak on the future of point-of-care testing on aspects of access and equity. Because if it has to be accessible, it really should be as point-of-care as possible. And Puneet is a senior program officer at the Bill and Gates Melinda Foundation in Seattle. And he was in India for some time, and he's currently involved with developing new tools and strategies to solve challenges in global TB control, to help countries and programs to figure out how to best use these diagnostics. Our second speaker is Dr. Mark Nicol, and he is going to speak to us on the role of new technologies in diagnosing TB, lessons from the South African experience. Mark is a clinical microbiologist with a particular interest in TB and in developing and testing newer diagnostics suitable for the developing world. His joint position with the University of Cape Town and the National Health Laboratory Service of South Africa allows him to sort of balance and coordinate activities of research with both clinical and laboratory teams involved directly in patient diagnosis and care. Our third speaker is Sanjay Sareen. Sanjay is going to speak to us on COVID experience in setting up PCR labs across the country. Sanjay is the head of FIND. FIND stands for Foundation of Innovative New Diagnostics, and he heads the India division and is really instrumental in laboratory strengthening and expanding access to high-quality TB diagnosis with the Central TB Division of the Indian Ministry of Health and Family Welfare. He also has been instrumental in setting up several PCR labs across the country, and he's going to give us his perspective. And our last speaker is Sandhya Krishnan. She's going to speak to us from a perspective of being a TB survivor on the challenges of TB diagnosis in India. Sandhya is a lawyer, she's a TB survivor, as I said, and she's a life coach. So friends, I invite you to listen to the words of wisdom from our four panelists, and I promise you it's going to be an exciting time. Thank you.
Hello, my name is Sandhya Krishnan. I'm a TB survivor and a wellness and mindfulness coach. I would like to bring the survivor's perspective into the discussion on equitable and accessible TB diagnosis in India, with a special focus on the impact that COVID has had on our journey as patients and survivors of TB. So it's no news to us that we are the TB capital of the world, and yet to many of us, it is unbelievable that we still face so many challenges for diagnosis in India, even today. I'll start at the beginning of the TB journey, so to speak, where thousands of us still suffer from incorrect diagnosis and treatment here. I am a case in point where I had no idea that I was displaying symptoms of TB to start with. I was guided to a general practitioner who gave me a collection of pills, one of which was antibiotics, I presume, and was just told that I'd be fine in 2 weeks, was not called back for a follow-up, or was not recommended any tests. And like most people, I was just trying to keep heart and health together, working a long day. It didn't even strike me. And there's a certain anger and outrage that I felt that my TB could have been diagnosed 2 or possibly 3 months earlier than it finally was. And I can only imagine what people with far less access to healthcare must go through on a regular basis and continue to go through from the reports that we get. The impact of this diagnosis is exactly what I just described. There is a huge suffering. The cost is exponential because we're running from pillar to post, very often having to repeat tests and not really knowing where all of this is leading us. There's nobody to guide us on this journey. There isn't enough information or transparency or someone to break it down for those of us that don't understand medical speak, and there is a lot of neglect. I do know that the healthcare system is hugely taxed, but there is a sense of nobody having time for us, and that we are somehow a burden on the system, and any kind of handout that we get in terms of attention or care is really a huge favor that's being done to us. I do believe truly that that's the narrative that has to change, and especially when it comes to drug-resistant TB patients. In diagnosis as well, there are several challenges that we face. We don't understand the different kinds of TB, how contagious it might be, what care we need to take of ourselves, of those around us, how we need to plan our lifestyle, our nutrition, our treatment even, more than just taking the pills. And I feel like having support through this journey can make a huge change if indeed we want to be that TB-free country that we have stated so vocally we will be this year, if I'm not mistaken. In terms of the kind of tests that exist versus the kind of tests that we have access to, I do believe there's a huge gap there today as well. I certainly wasn't aware of what tests look like, and this is despite my mother being a doctor and a microbiologist at that, just not one in India, right? So what else is out there in India? What the private sector offers, what the government sector offers, and I really, our hope is that there shouldn't be a divide amongst this. What new technologies are coming out? Again, from a lot of us survivors, there's a sense of anger and outrage that the world rallied around so successfully to find solutions and to beat COVID. I may be speaking too soon, but TB is taking decades, and are we just languishing, and are we just not moving fast enough to create the change for a disease that's so preventable, so treatable, and for deaths that are so unnecessary? We believe that there is a need for some fundamental changes, particularly in the areas of diagnosis, the kind of tools that are currently being used, and just the efficacy of it. So much more sophisticated technology does exist in the world today. We would like to have access to it sooner rather than later. And I think all it takes is strong will on the part of all of the stakeholders, and we can truly make this happen. Because healthcare, at the end of the day, is a human right. A lot of us believe that TB is not a personal disease. It really is a failure of the healthcare system, of society, and really to be TB free and to have access to diagnosis, treatment, support through this journey that is horrific in itself is really a fundamental right for each of us. Even in the public sector, where TB care services are offered free of costs, there are a lot of hidden costs, for example, that are not taken into account. It's not just about diagnosis, but hospital stays, how often you get access to review of X-ray results, travel to get your medication, travel to see your doctor. I know of people that dropped out of treatment in the government sector just because they couldn't take a day off work that it took for them to go and wait at a dot center for their medication. These challenges pose a serious economic barrier to accessing care and complementary treatment. And if this is a fundamental right, we would like for it to be exercised and respected. Stigma is another big problem that often goes unaddressed. Again, somehow the focus is always on just getting us to have the medication without any of the societal or the mental aspects that accompany this disease. TB is as much, if not more, societal and mental as well. And we would really like for those conversations to happen louder and with multiple stakeholders. Not only does every TB patient face stigma and very often a lack of understanding for ourselves as well, but there are several groups that are far more vulnerable, and especially those that have comorbidities or belong to groups that are already stigmatized by society, such as HIV patients, transgender patients, and other patients that might be suffering from mental health disorders as well. The pandemic has had mostly a negative impact on our journey as TB patients and survivors, accessing healthcare, being able to get diagnosed on time, being able to access medication. Everything that was already a problem pre-COVID became so much tougher during COVID. And I think if there is a strong will now to fight COVID, there has to be an even stronger will to overcome the difficulties and the setbacks that we faced in the last 2 years. I will also say that some of the behaviors and conversations around communicable diseases, use of masks, we could take some of the best practices from that and apply them to TB as well. And many of these actions have now been normalized. Those conversations should definitely be taken forward in the treatment of TB and in the managing of the disease as a whole. I'll recap by saying that the need of the hour is an urgent need to establish and implement a gender-sensitive, people-centered approach to diagnosis and treatment of TB, in terms of affordability, in terms of awareness, in terms of challenges faced by the public and the private sector, in terms of costs, access to technology, access geographically. If vaccines could reach every corner of the country, surely TB treatment and diagnosis can as well. Access to support in terms of mental and social issues, and more awareness and treating TB as in this basket of communicable diseases, of which COVID is one. So I hope our voice will be considered when we're having discussions around this. Our hope is that we will see the end of TB very, very soon. Thank you so much.
A very good morning, afternoon, and good evening to delegates, colleagues, and partners who are attending this very important TB summit. The SARS-CoV-2 outbreak has highlighted the huge gaps in ability to test and manage widespread pandemics globally and in India. Challenges in the diagnosis of SARS-CoV-2 infections have emerged as a critical point of failure in the COVID strategic preparedness and response plan. There are gaps in both availability of tests and trained laboratory personnel. Over the last 2 years, India has taken great strides in building its COVID-19 diagnostic capacity. From having less than 20 labs in March 2020, the network currently has greater than 3,000 labs, with almost 2,000 labs in the private sector. In addition, there is a large network of antigen testing sites that has been established. The country has also established strong sequencing capabilities via the INSACOG network. India's testing rates are also tracking well as per the recommended WHO testing rates and stands on par with some of the high-income countries. There have been some important learnings from India's response to the pandemic, which in fact can be leveraged to develop a resilient pandemic preparedness system to protect the country from future threats. These include an unprecedented speed of regulatory approvals and simplified import procedures to ensure rapid availability of tests, strong focus on local R&D and innovation, which resulted in the development of tests like TrueNAT, the CRISPR, as well as the RT-LAMP-based tests, and rapid adoption of testing innovations like professional use antigen tests and self-testing antigen tests. India, in fact, was one of the first countries to come up with a policy on self-testing. There has been a strong private sector participation right from the beginning, and that has in fact contributed to the rapid scale-up of the testing network as well as the labs. To ensure quality, the government has ensured that only the ISO 15189 private sector labs are onboarded. The workforce has been rapidly expanded because of the large and huge focus on the training and capacity building, which now means that the country has a ready-made pool of skilled lab technicians, which can be leveraged to manage to mitigate threats from future pandemics. There have been strong intersectoral partnerships. For example, ICMR availed the services of the Ministry of Civil Aviation to deliver consignments of diagnostic material through mission Lifeline Unan. The near real-time data tracking has enabled analyses at district, state, and national levels to support rapid decision-making. And last but not the least, the government has very rapidly responded to the threat from emerging variants of concern by setting up INSACOG, a network of 38 labs to monitor genomic variations in SARS-CoV-2. Changing tracks a little bit, COVID-19 pandemic, while we all know has impacted livelihoods, it has also adversely impacted health systems across the world, including disease programs like HIV, TB, and malaria. The number of new cases of TB, which were rising steadily between 2016 and 2019, dramatically fell by 20% in 2020. India, in fact, contributed to the biggest drop in the detection of new cases, with 41% of the total number of cases that dropped in 2020 coming from India. It is therefore critical, in order to prevent disruption to TB detection, that TB diagnosis be opportunistically integrated with screening of respiratory illnesses, like, for example, COVID-19. In line with this, the Government of India, Ministry of Health and Family Welfare, they in fact issued a guidance which urged the state governments to rapidly conduct bidirectional screening of TB and COVID-19 presumptives because of the similarity in the symptoms of the two cases. There are two case studies which I would very rapidly walk you through. One is an experience from Kerala where both the cases, the influenza-like illnesses, as well as the severe acute respiratory infectious cases from OPDs and IPDs were subjected to this bidirectional screening. X-rays as well as oral questionnaires were used, and all the presumptives were offered NAT testing. And this resulted in a significant increase in the TB yield, almost 200 of the 100,000 screened in the ILI cohort, and nearly 988 cases detected of the 100,000 screened in the SARI cohort. There was another similar intervention which was implemented by FIND in collaboration with MCGM and IHF in Mumbai. Here, walk-ins in 4 government hospitals at the COVID-19 OPDs were screened with the TB questionnaire. The positives were isolated, and then the phone TB screening was conducted after 14 days of quarantine. The walk-in patients at the TB OPDs and the health posts were offered rapid antigen testing, and all the presumptives were offered NAT testing through either GeneXpert or TrueNAT. More than 15,000 COVID-19 OPD walk-ins were screened, and almost 219 of 100,000 cases screened were diagnosed as tuberculosis. And there has also been guidance from global agencies like USAID and STOP2B partnership around the integrated diagnostic approach, and this study from Mumbai has now also been published in Lancet Global Health. This is another quick experience from Nigeria where GeneXpert and digital X-ray CAD were used, and they in fact brought in HIV, HPSAG, and HCV as well, and resulting in a strong TB yield of almost 570 per 100,000 cases screened. Very quickly, coming to some of the learnings from this integrated screening, absolutely critical to have an integrated touch point in order to offer the best experience for the patients so that they don't have to move around and increase the risk of infection. Try and use a single sample type and test cartridge. There are innovations happening in this space. For example, there is a new MTB plus COVID test, which will simultaneously be able to test for TB and COVID. There needs to be strong coordination between the vertical programs who are implementing, that is those who are implementing COVID-19 programs, as well as the TB and the HIV programs. Readily available and dedicated area for sample collection. And last but not the least, there has to be a constant push to be able to maximize the utilization of the machines and the human resource personnel which are deployed for these interventions. Some of the lessons from the COVID-19, basis strong investments in the diagnostics, absolutely critical to continue focus on integrating multi-disease platforms, keeping the patient in the center and leveraging the massive testing infrastructure. Continue investments in research and development to ensure there is a reduction in dependence on imports and fill up to the local diagnostics innovation. Continue investing in skilling to augment the laboratory capacity so that we have a ready-made laboratory workforce. And incorporate a system strengthening approach which integrates and connects diagnostics with surveillance system to ensure that we are picking up early signals and are able to manage our pandemics and outbreaks better. And the strong backbone of genomic surveillance which has been built through the INSACOG, there is a need to continue investing in that so that you can not only track the spread of TB and resistance, but also other emerging pathogens. Thank you.
Hello. I'd like to thank the organisers for the invitation to present at this summit. And what I'd like to do in the next couple of minutes is just share some of the lessons that we learned in South Africa from the implementation of new technologies for diagnosing tuberculosis. And I'd like to start by contrasting these two assays over here. Expert NTB-RIF and the ALEA-LAM lateral flow assay. Now on the face of it, one would anticipate that the ALEA-LAM assay would be much more successfully and more rapidly implemented than the GeneXpert assay. Expert requires a complex instrument, it's costly, requires a power supply, is a laboratory-based rather than a point-of-care assay, requires collection of sputum, and in clinical studies, including meta-analysis, has shown that although it reduces time to treatment and improves the proportion of patients started on treatment, has limited impact on patient mortality. In contrast, the ALEA-LAM is a simple, relatively inexpensive test. It can be done at the true point of care at the bedside of the patient. It relies on urine collection, which should be simpler to obtain than sputum. And a number of studies have demonstrated that in patients with advanced HIV infection, rapid implementation of treatment on the basis of ALEA-LAM results can reduce mortality. However, the experience from South Africa was that while Expert was rapidly implemented and became widely available across the country, this was not the case for ALEA-LAM. So on the map on the left, you'll see that in 2019 already, 203 sites had implemented GeneXpert testing, and more than almost 15 million tests had been done across the country. In contrast, even until now, there's very limited data on ALEA-LAM implementation, but implementation is patchy, and the test is not widely used except in selected tertiary care settings. So why is this? Well, there's some obvious answers. The first is that while GeneXpert is both sensitive and specific, and can be used in a wide range of patients ranging from children to pulmonary and extrapulmonary TB, the ALEA-LAM assay is relatively specific, so a positive test can be used as the basis to start TB treatment, but is insensitive and really only has useful sensitivity in patients with advanced HIV infection. However, I believe there's some broader lessons which can be learned from this The first is that laboratory services can be powerful vehicles for program change. Following the decision to implement GeneXpert in South Africa, the National Health Laboratory Service, which provides laboratory testing for the state sector in South Africa, was put in charge of rolling out the GeneXpert assay. The laboratory services selected the sites, purchased the equipment, made sure the consumables were available, set up the quality assurance systems, and developed the algorithms for implementation. In contrast, because the ELIA-LAM assay is a highly decentralized test done by clinicians at the point of care, we found that inertia was a very strong force. It was difficult to change entrenched practices, supply of tests was problematic, and simply getting clinicians to start using the assay has not proven easy. Part of this may relate to political will. So following the WHO recommendation on GeneXpert in 2011, the South African Minister of Health made a decision. He said GeneXpert would be used as the replacement for smear microscopy, and he allocated this responsibility to the laboratory services. In contrast, there was no similar decision or recommendation from a senior government minister around the implementation of ELIA-LAM. The final lesson in relation to this, I believe, is that complexity is the enemy of implementation. So whilst for GeneXpert this was relatively straightforward, GeneXpert was to be used as a replacement for smear microscopy for primary diagnosis of pulmonary tuberculosis. A simple implementation message. In contrast, a considerably more complex algorithm had to be developed for ELIA-LAM. This test was only to be used in HIV-infected patients, in those with low CD4 counts or advanced infection, those who were hospitalized. Decisions had to be made on whether a test could be used as the basis for treatment or whether a test could be used to rule out tuberculosis in this patient group. And this resulted in considerable debate over an extended period of time about what the optimal algorithm was. And in fact, the algorithm was only finalized a year or two ago, many, many years after the test became available. The next lesson which I'd like to mention, and this should be a really obvious one, is that tests don't work without specimens. And for here, I'd like to highlight our experience with diagnosis of pediatric TB in South Africa. So we and others were amongst the first to evaluate GeneXpert and other tests for diagnosis of pediatric TB. And we showed that the tests were relatively sensitive, detecting around 60 to 70% of culture-confirmed TB in children. But of course, you can only do a test if you have a specimen. Most of the TB in children in South Africa is children under the age of 5. Those children are unable to expectorate spontaneously, and so we need to collect gastric aspirates or induce sputa to perform testing. And we haven't been widely successful in implementing collection of those specimens outside selected tertiary care centres in South Africa. And so either we need to do a better job at making sure that specimen collection becomes more widely available, or we need to find alternative specimen types in these patient populations. The final lesson I'd like to mention here is that tests only have impact if results are actionable and actioned. And so what do I mean by actionable? Well, let's use the example of children with TB in South Africa again as an example. So in South Africa, with a high prevalence of tuberculosis, empiric TB treatment of children on the basis of clinical presentation is the norm. In this setting, there's very low appetite for implementing tests for this population that have relatively low sensitivity. So for example, a clinician with a child with suspected TB will say, well, why must I do a GeneXpert test? Irrespective of the result of the GeneXpert test, I'm going to start this child on TB treatment. Of course, there are counter-arguments, in particular, the ability to confirm TB and rule out other diseases, and additional information on drug resistance that one obtains from microbiological testing. The second point here is that even when tests are actionable, they're not always actioned due to health systems failures. And the example I give here is the proportion of patients with drug-resistant TB who were diagnosed by GeneXpert and started on treatment. And here, this figure over here shows a study that we did in Khayelitsha outside Cape Town, looking at time to treatment of patients with drug-resistant TB on the x-axis, and on the y-axis, the proportion of patients diagnosed with drug-resistant TB who were started on treatment. And you can see that even after implementation of GeneXpert in 2013, only 60 to 70% of patients were started on treatment after diagnosis of drug resistance. And this is because of health systems failures in recalling the patients and getting them onto treatment. However, the final lesson is that when we get this right, it's certainly worth the effort. And this is an example from Khayelitsha, again in Cape Town, where we explored time to treatment initiation with implementation of a range of different diagnostics across the years. And you can see that in the early 2000s, the median time to treatment of patients with drug-resistant TB was around 70 days, with implementation of line probe assays, followed by decentralization of care for patients with drug-resistant TB, and implementation of GeneXpert. By 2013, the median time to treatment for a patient with drug-resistant TB was 7 days. So an enormous achievement and a substantial improvement in patient outcomes. I'd like to thank my colleagues, particularly Helen Cox, the children and adults who've participated in our studies, and our funders. Thank you.
Greetings. I'd like to share with you a few points and thoughts about the diagnostic access gap and the need for point-of-care testing. The context of this presentation comes into the principle of that we are missing millions of patients with TB. The map on the left shows the estimated TB incidence for 2020, and you can see, of course, India dominates by the number of TB cases. And the figure on the right shows who's missing. That is the gap between those that are notified and those that are estimated to occur across both men and women. And the numbers are large. We're missing millions, and many of those are from India itself. Now, where are these patients being lost? The diagnostic gap is the biggest drop in the cascade of care we have. Across all countries, when you aggregate the information, between that estimated incidence and the patients who are diagnosed is where we're missing, a third of patients in the case of drug-susceptible TB and half to two-thirds of patients in the case of drug-resistant TB. It's interesting to put this in context of every other diagnostic out there, because this problem is actually particularly notable for TB itself. If you look at all other essential diagnostics as judged by the WHO across all levels, whether it's the basic primary care level or the advanced primary care level or the hospital level, what we find is that you can, even if access to other essential diagnostics like malaria, HIV testing, and urine pregnancy tests and others are there, TB access is not. And that's true very much at the basic primary level, where just about 12% have microscopy, shown on the left in the Lancet Commission on Diagnostics. At the advanced primary care level, you find out half with microscopy, and very marginally or rarely would find more specific TB diagnostics in the form of molecular testing. You do find it sometimes in hospitals at about a half to two-thirds, but that's not where patients are. While there has been some modest improvement in the availability of so-called WHO-approved rapid diagnostics, or WRDs, shown at the table on the right, that the number of people who get that test at the point of diagnosis is far below the global targets. In this case, global target for 2020 was 80% of patients who are diagnosed should have a WHO-approved rapid diagnosis at the time of diagnosis. That number was only about a third. And in fact, in India, it was close to 20%. That's kind of an amazing number. And one of the core problems is, as I showed you a little bit earlier, that across all aspects of the care cascade, when you look at where people seek care, whether it's in public or private sector, which is circled in red there, what you find is those are the places where it's uncommon to have TB diagnostic access available. It's a refer out or send out in almost every place. That's about 30% overall across all countries, and about the same in India. Why does this matter? It has been shown relatively convincingly that on-site molecular testing increases patients diagnosed and treated. First example here comes from India itself with a demonstration of GeneXpert when it was first released a decade ago. So it's not new information. When Expert was replacing smear microscopy just in the public sector facilities, they found about a 15% increase in the total amount of patients who were diagnosed and put on drug across all cases, clinical cases, microbiological cases. And there was a 5-fold increase in detection of rifampicin-resistant TB. More recently in Uganda, a cluster randomized trial across 20 clinics, again, had a striking increase in not only the transition from standard of care, which was basically microscopy with expert referral when needed, having on-site expert availability in that setting increased your proportion of patients who got diagnosed at 14 days by a lot, okay, by over 30%. And more importantly, increased the quality metrics across every step along the diagnostic evaluation, including the time to treatment, getting a DST, and everything got better. So it's clear that having diagnosis where people seek care makes a difference. But why hasn't this happened everywhere, since really we've had a decade to figure this out, certainly in India? One core issue is cost. As one senior program officer mentioned to me several years ago, that if we transitioned to expert at that point in time, it would more than double the amount of money the government had allocated at that time for TB. The supply of the diagnostics is non-trivial. Many of these previously were imported, although that's been recently partially addressed by the presence of new indigenous products like Molbio's TrueNat, which could address some of the reliance on external supply. In fact, that external supply was even more unreliable during the pandemic. A lot of this is just priority. How much are we going to be bothered by, investing in needing TB diagnosis versus just letting people get diagnosed the way they were and having this available just as a DST? People previously thought molecular testing was just unscalable. You couldn't put these things in austere settings. Probably the most important thing is just straight up the willingness to pay for seeing that this service becomes available to patients as they need them. And I think that is probably the core thing that has to change. People who thought that molecular testing wasn't scalable have been proven dramatically wrong by the events of the pandemic. And India's COVID-19 PCR testing success story is probably the best answer to that concern. India does more than 1 million tests a day. And take that against 10 million tests a year for TB across microscopy and GeneXpert, roughly speaking. Now, the 73 crore total, almost 750 million COVID-19 molecular tests that have been reported over the past 20 months in India dwarf the 20 crore TB tests that have been conducted over the last 20 years. And most of that's just microscopy. Only a small fraction would be an advanced molecular test like what's happened here. So I think we've proven that molecular testing is scalable. And the question is how to report that capacity and willingness, more importantly, to seeing that TB testing becomes available where patients need it, not just COVID testing is available to anyone in India who wants one kind of anytime. There are a number of pipeline products that are coming down the pipeline which can help bridge this diagnostic access gap. We're enthusiastic about oral swab-based molecular testing, which can be plugged into this massive existing PCR capacity that India exists. This could also be plugged into existing diagnostics like Expert and Molbio's TrueNat. And there are pipeline platforms by companies like LumiraDx amongst many, and consumable NATs, disposable devices, where we might be able to take this non-sputum specimen and deploy it into. And that's great because that increases the access base of people. They don't have to rely on sputum processing. And at the same time, everybody knows how to do a swab. We're sick of them. But they work apparently almost as good as sputum and TB. And we'd like to see those protocols promptly reviewed by ICMR and approved. And there are some urine assays which might be able to augment that molecular capacity in austere settings. So it's possible to address this gap. And I think we'll hear more about this in the upcoming presentations. Thank you very much for your time. I want to thank all of our speakers for their interesting presentations. For my closing remarks, I just wanted to highlight a few points from the presentations as well as make some suggestions for the subsequent discussion. First, I think we heard that there's a substantial diagnostic gap in TB, and in particular a gap in the delivery of WHO rapid diagnostics to patients at the time of diagnosis, with only 20% of patients in India having that test at the time of diagnosis. Second, we heard that there are some interesting and promising tools in the pipeline, some of Indian origin like TrueNat and Mobio, which are increasingly available, but not quite there yet in terms of being routinely available for most patients. And some additional pipeline technologies which offer the opportunity for more decentralized diagnosis moving forward, which is great. Third, that we heard that COVID-19 has had an enormous impact and a negative impact on TB and health service utilization in general, and TB case finding in particular. And that's really challenging for patients and challenging for the program to recover from this setback. Then we heard that some of the remarkable experiences from India's effort to rapid response to deliver COVID-19 testing to its population, some of the incredible mobilized efforts and the results were sort of stunning in terms of the number of tests that could be delivered to people when the political will was able to be summoned. And lastly, that some interesting and innovative approaches for things like bidirectional testing through the pandemic and efforts to try and recover ourselves out of this hole of case finding that COVID left us in. So a lot of really interesting experiences and lessons, but the fundamental problem remains. Most patients aren't getting the right diagnostic test when they need to at the time that they're suspected of having TB. They're still subject to clinical and ancient microbiological diagnoses, not actually getting the tests that are even available. And my basic questions, perhaps for points for reflection, are first that clearly India can do this. If you can test a million patients a day with molecular tests for COVID-19, I think it should be possible to get to, a million patients a month for TB with molecular tests, which is all it's going to take. So I think there's an incredible capacity and capability that's been demonstrated under the duress of the past few years, which now needs to be harnessed for the disease that's caused nearly as much damage on an annual basis for the past many years. So I think that there's no excuse anymore. Second, that it'll be crucial to find a pathway to leverage the diagnostic capacity that's been made, not just in terms of the technologies and tests, but also in the human systems for collecting specimens, for getting those to a laboratory, for returning a result to patients and providers almost within hours, and reporting those to public health authorities for subsequent action. Like those systems that were built for COVID now need to be harnessed for TB. So I'm looking forward to the opportunity that the pandemic dividend might allow for not only catching up out of the hole that COVID has left us in, but actually moving forward towards the national goals of TB elimination with a redoubled effort because of the diagnostic advances that have been made under duress because of the pandemic. With that, I'll invite the live question and answer session that for the presenters and the audience that might be assembled. And thank you very much for your attention.